Right, now Professor Surishti Raj is also with us, and he'll talk of now that we've done. Now what may go wrong? Now let's see.
Uh, Thanks, Dr. Susmita, being a part of this IC. So, there is no financial interest involved. So, what can go wrong after the mix has been done? We know that mix has a high safety profile and it's a safe surgery compared to the trap or other stents like ADI or AGV. But complications do occur, though the most of the complications are mild and may resolve of its own. So, the different mix done are trabeculotomy, goniotomy, GAT, bank, KDB, trabectum. All these are done here also, except the lower one, which are definitely cost effective. So, maybe very less is been done. So, with mix we target different structures like TM, Schlem's canal in incisional or excisional surgeries, or subconjunctival space like pressure flow or Zen, and suprachoroidal this CyPass, and canal based like Hydrus or Omni. So, benefits or mix are, he says, high safety profile, and it can be combined with FICO or can be done as a standalone procedure also. Usually it doesn't cause hypotony, and future trabeculectomy is not affected as we have it naive conjunctiva. So, there is a long list of complications of all mix, and common are hyphaema, IOP spike, then implant related like dislodgement or malpositioning or decimal detachment, retrodialysis, and rarely cyclodialysis also, and peripheral anterior synecdoche formation, which is more with GAD than other MIT, and postoperative inflammation. And rarely you could see retinal detachment or choroidal detachment, CME, IOL dislocation or TCO, or sometime infection also. So, how to avoid or minimize complications? So, one must be very uh, uh, well versed with the technique of gonioscopy and do the procedure only if you are seeing the structure, and don't go blind and just assuming that you are doing the right thing. So, complication may still occur, though most of them can be managed. So, peroperatively, by giving the incision, there could be hyphema or iris trauma or DMD or cyclodialysis rarely, false passage like we see with GAT or some blood ooze, and postoperatively there could be peripheral anterior synecdoche, corneal edema, rebleed, trabecular meshwork scarring, IOP instability, sometimes vitreous hemorrhage, even malignant glaucoma and persistent inflammation. So, mix though have high safety profile, but it is a relatively safe procedure compared to other with minimal tissue trauma. But complications do occur, and most of them resolve spontaneously or are manageable. Hyphema occurred in as high as 70% of the cases, but most of the time it is mild and transient. And if it is not resolving, then you may have to enter again. And sometimes retained viscoelastic is there, or transient rise in intraocular pressure, and other complications like PAS, CME, post-op inflammation, rarely hypotonia or infection. These infections have been seen more commonly with the implant, and it is less than the incisional surgery where we don't put any implant. So, specifically trabeculotomy, goniotomy or canaloplasty, we see hyphoma more often, mostly transient, and DMD can occur if the viscoelastic is injected into it, or iridodialysis if you are not focused enough, or if there is a bulge of the iris, and cyclodialysis though rare can occur, and false passage that is seen more with GAD, and BANG and GAD and KDB, they are almost similar complications. Common ones are hyphema and IOP spike, and vision threatening complications like corneal edema, cyclodialysis or DMD can occur, and rarely vitreous loss or hemorrhage, vitreous hemorrhage can occur, and iridodialysis. So, other is GAD apart from hyphema and IOP spike, then suture related complications at various stages can occur like initializing the goniotomy, or sharp suture tip due to sharp suture tip, or deroofing during deroofing, uh, false passage, then PAS they have been seen more with GAD than other MIT surgeries. So eye stent, the specific complications related to eye stent are hyphema and malpositioning or displacement. Sometimes blurring of vision or anticipated post-operative other events. Then obstruction of the eye stent, IOP spike, endothelial cell loss is seen with most of the stents used, though it is less with eye stent, and it was more with CyPass, which has been absolute no. So some other bleb forming mix like Zen and pressure flow, both are similar. One is ab interno and one is ab externo. Only thing is the bleb formed with pressure flow is little posterior than the Zen, and there can be malpositioning or conjunctival perforation or hyphema, device exposure. Then bleb related fibrosis or scarring and capsulation. Bleb infection are rarely end up or suprachoroidal hemorrhage and DMD can also occur. So this hydrous stent can cause transient hyphema, malpositioning or displacement, PAS or obstruction or malfunctioning, IOP spike and even migration. So this is the recent article where the surgical success of standalone MIGS was compared against the MIGS with cataract surgery. So the criteria was IOP of less than 21 or less than 20% from the baseline without increase in glaucoma medications and with without additional lasers or incisional surgeries and without loss of PL vision. And in combined surgery, all of these, but with just a decrease of one glaucoma medications. So what they have proposed that before going for MIGS, you can always try SLT, that will give you a decrease of one or two medications. Other thing is, if you are going for trap, it is very important to manage the trap in post-operative period aggressively, because it is the period where the most of the trap failure, and there should be aggressive steroid use and appropriate time of releasing the sutures and going for anti-metabolite injections. So if you manage post-operatively trap well, it is a good surgery and give more magnitude of IOP reduction. So concluding, MIGS have significantly advantaged treatment of glaucoma, offering safe and less invasive procedure. But careful case selection is key to avoid complication, ensure normal BP and discontinue anticoagulants. Though complications are low, but still DMD, PAS, ECL, implant dislodgement, hyphema, iridolysis can occur. Prevent hypotony at any step during MIGS surgery and master the art of gonioscopy. If you are well versed with gonioscopy, only then you can go for MIGS surgery. And patient counseling regarding outcome, that is decrease of one medication or limited decrease, that is very important because it's a costly procedure. Thank you.
Thank you, Dr. Surishti.